Imagine your heart right now just beating in your chest. Usually it's this perfect, reliable metronome, tick tock, squeeze, release.
Yeah, completely in the background.
Right. It's this masterpiece of biological engineering, and it quietly does its job without you ever having to think about it.
And we take that predictable rhythm entirely for granted. I mean, the moment you start actually feeling every single heartbeat, something has fundamentally changed.
Exactly. But imagine that metronome suddenly shatters. It just breaks and turns into this chaotic, quivering storm. It starts firing completely out of sync, totally unpredictable. That is atrial fibrillation.
Or what you'll usually hear called a-fib.
Yes, a fib, which is what we're diving into today.
It's the absolute definition of electrical chaos inside the human body.
It really is. A-fib completely rewrites the rules of how the heart is supposed to function, changing it from this organized pump into an erratic, trembling muscle. And so today, we are exploring the clinical and historical notes on a-fib, specifically focusing on the nursing and medical angle. We're calling this deep dive the irregular rhythm that throws clots.
I like that title. Very accurate.
Thanks. We're going to unpack what it is, why it quintuples your risk of a stroke quintuples, and how the medical understanding of this condition has flipped like multiple times over the decades.
And understanding this is so crucial for you listening because AFib is not some rare medical anomaly. It is one of the most common sustained arrhythmias on the planet.
Yeah, it's everywhere now.
It really is. Our global population is aging, which means prevalence is just skyrocketing. I mean, millions of people now have smartwatches buzzing on their wrist with these irregular rhythm alerts.
Which is terrifying to wake up to, I'm sure.
Oh, absolutely. So whether you're a nursing student cramming for the NCLEX or a medical professional or just, someone trying to track your own heart health, a-fib is something you will inevitably encounter.
And it's wild to think we're now getting wrist alerts for something doctors spent literally centuries trying to decipher just by touching a patient's wrist.
Right. The history here is fascinating.
The historical notes show physicians were noticing these highly irregular pulses long before they had any clue about the underlying mechanism.
Yeah, you can actually trace it back to 1749.
1749, that's what, George Washington was a teenager?
Basically, yeah. There was this French physician named Jean-Baptiste de Sénac. He was feeling the pulses of patients with severe mitral valve disease and documenting this highly irregular, rapid pattern.
Just by touch.
Just by touch. But the terminology really became evocative, I'd say, in 1876. That's when a clinician named Carl Wilhelm Hermann Nothnagel described the phenomenon simply by feeling it at the bedside.
And he gave it a great name.
He did. He coined the term delirium cordis.
Delirium of the heart.
Exactly.
That is just an incredibly vivid way to describe a pulse, but purely descriptive, right? I mean, they had absolutely no mechanistic explanation for why the heart was delirious.
Isn't it all? To move from feeling a delirious pulse to actually mapping an electrical storm, that required a massive technological leap.
Enter the early 1900s.
Yes. A Dutch physiologist named Willem Einthoven invented the string galvanometer.
Which sounds like a steampunk instrument.
It kind of was. This was the first real electrocardiogram, the ECG, and it actually won him the 1924 Nobel Prize.
I always wonder how they actually pulled that off before modern computers. Like, how do you visualize human electricity in the early 1900s?
Well, it was a brilliant piece of analog engineering. Einthoven suspended this microscopic silver-coated quartz string.
Wait, an actual physical string?
The physical microscopic string. He suspended it between two powerful electromagnets. And when the tiny, almost imperceptible electrical currents from a patient's heart passed through that string, the magnetic field caused it to twitch and move.
That is unbelievable.
Right. And he shined a bright light on it, so the moving string cast a shadow onto a scrolling roll of photographic paper.
So the shadow of this twitching string physically drew the electrical waves of the heart.
You got it. The very first ECG tracings. Einthoven captured these early recordings showing a chaotic, undulating baseline where the normal, organized electrical wave, what we now call the P wave, was just entirely missing.
Just gone.
But it was British cardiologist Sir Thomas Lewis who put the puzzle together around 1909. He connected Einthoven's visual tracings to that delirium cordis that clinicians had been feeling for, 150 years.
And he coined the modern term, right?
Close. He coined the term auricular fibrillation.
Oh, because atria were called auricles back then.
Exactly. But he proved that the irregular pulse was the surface signature of disorganized electrical activity.
So let's talk about that disorganization, because under normal conditions, you have the SA node, the sinoatrial node, that's your heart's natural pacemaker. It sends one clean, sweeping electrical wave down through the upper chambers, the atria, to trigger a coordinated squeeze.
One clean wave.
But in a fib, that clean wave is completely hijacked.
It is. Instead of one wave, you have 400 to 600 disorganized microwavelets firing simultaneously every single minute.
400 to 600 impulses a minute is terrifying.
It's pure static.
If those all went through, the heart would just vibrate itself to death, wouldn't it?
It would be entirely unsurvivable, which is why the AV node, the atrioventricular node, is so critical here.
The biological gatekeeper.
Right. It sits between the upper and lower chambers. The AV node gets bombarded by these 600 impulses, but it just refuses to let them all pass.
Yeah.
It only lets an irregular, unpredictable subset of them through to the ventricles.
Which is why the hallmark physical finding of a fib is that irregular pulse. There's no repeating pattern in timing or strength.
None.
It makes me think of a frantic bouncer at a nightclub.
Oh, I like that analogy.
Yeah, so you have this unruly mob of 600 people outside the doors just pushing and shoving, and the bouncer's totally overwhelmed. He's just randomly grabbing people. You can go, you stay, you go, you go, you stay. He's only letting a random few through the door at a time. And the result on the dance floor, the ventricles, is completely unpredictable.
That is perfectly put. The ventricles are only responding to whichever impulses the AV node lets pass the velvet rope.
But diagnosing this isn't just about feeling the chaos anymore.
No, to formally diagnose this chaos, the American Heart Association, the Heart Rhythm Society, and the European Society of Cardiology all require a very specific threshold. You need to see this chaotic activity on an ECG for at least 30 seconds to officially call it a fib.
Wait, why 30 seconds?
Good question.
Like, what if my heart quivers for 28 seconds? Is 30 just a neat round number someone made up to make medical textbooks look organized?
It sounds arbitrary, I know, but shorter runs of atrial irregularity are actually quite common in human beings, and they're usually clinically insignificant.
Oh, really?
Yeah. The 30-second cutoff was specifically chosen because that's the threshold where the finding becomes highly reproducible on clinical monitoring and, more importantly, clinically actionable.
Meaning that's the point where a patient's risk profile demonstrably starts to shift.
Exactly.
And that risk shift is huge, because if the heart is just quivering and not doing that nice clean metronome squeeze, the blood itself is not moving properly.
No, it's not.
And that mechanical failure leads directly to the deadliest consequence of a fib.
The clot.
The clot. To understand this clot risk, the notes bring up a 19th century concept called Virchow's triad.
Yes, Rudolf Virchow. He outlined the 3 perfect conditions for thrombosis or blood clotting: stasis, endothelial injury, and hypercoagulability.
And all 3 of these play out with devastating precision inside a fibrillating atrium.
They really do. Let's start with stasis. Because the atria are quivering like a bag of worms instead of firmly contracting, the blood doesn't get squeezed out efficiently.
It just sits there.
Right. And there's a very specific anatomical spotlight here: the left atrial appendage, or the LAA.
Right. The notes describe it as looking like a small, wrinkled, ear-shaped pouch hanging off the left atrium.
That's a good description. It has a narrow opening and a trabeculated, which means highly ridged interior.
So when the atrium stops squeezing, the LAA basically turns into a stagnant puddle. The blood just pools in those ridges.
And because that blood is stagnant, it triggers the other 2 parts of Virchow's triad. The stagnant blood physically irritates and inflames the lining of that patch. That's your endothelial injury.
Okay, that's 2.
And on top of that, the state of a fib itself is independently associated with elevated levels of clotting factors in the bloodstream. So, boom, there's your hypercoagulability.
The perfect storm.
Exactly. This stagnation and inflammation trigger what is known as the coagulation cascade. Specifically, the body starts producing fibrin proteins. These proteins weave together into this sticky net that traps passing red blood cells, creating massive fibrin-rich clots.
These are often referred to as red clots, right? Because of all those trapped red blood cells.
Yes, red clots. And the result of this perfect storm is a striking statistic: 90 to 95% of atrial clots in non-valvular a-fib form, right there in that one tiny little pouch, the LAA.
90 to 95%, that is staggering.
It's almost all of them.
And it's not just that a clot forms, it's where it goes once it breaks free. Because when one of these massive red clots dislodges from the LAA, it shoots out of the heart right through the aorta, and it has a terrible tendency to go straight up the carotid arteries into the brain.
A direct flight to the brain.
It's not just throwing a pebble into the plumbing, it is sending a massive boulder straight toward the brain's main highways.
That's why these strokes are so severe. These clots are unusually large because they've been forming in that stagnant pouch. When they lodge in the brain, they block large proximal cerebral vessels.
Which is why the data from the famous Framingham Heart Study proved that a-fib does not just raise your stroke risk, it quintuples it.
5 times the risk. And these specific cardioembolic strokes are significantly more fatal and more disabling than strokes from other causes, precisely because of the size of the clot.
So, since these strokes are so catastrophic, clinicians have to figure out who needs blood thinners without causing everyone to bleed out unnecessarily.
Right? It's a delicate balance.
To solve this, they use the CHA urine Vasek score to tally up a patient's risk factors.
Let's break that acronym down for the nursing students listening.
Right, so congestive heart failure, hypertension, age 75 or older, diabetes, prior stroke or TIA, vascular disease, age 65 to 74, and sex category specifically, being female.
And each of these factors independently raises the baseline stroke risk. Generally, a score of 2 or more in men or 3 or more in women warrants putting the patient on a blood thinner. It's really a brilliant example of applying epidemiological data to risk stratification right at the bedside.
So you tally up the score, you hit the threshold, and you get a prescription. That seems incredibly straightforward until someone's Apple Watch chimes at 2 a.m.
Yes. The wearable tech disruption.
Sure. Modern technology is completely disrupting that neat scoring system. Historically, you either had a fib or you didn't. You went to the doctor, they hooked you up to an ECG, and boom, you were diagnosed.
Right, binary.
But now, implantable loop recorders and smartwatches are finding subclinical atrial high rate episodes, or AHREs, tiny episodes lasting just a few minutes.
And because of that, we have a flood of otherwise healthy people getting alerts on their wrists.
Right. And if my watch says I had a 3-minute episode, but I feel completely fine, like no palpitations, no dizziness, why would I take a risky blood thinner to treat a math equation on my wrist?
I hear this all the time.
Yeah.
But we have to firmly bust the myth that if you can't feel it, it can't hurt you.
Okay, let's bust it.
A substantial portion of all a-fib, up to half in some populations, is completely silent. You feel absolutely nothing.
Wow, to half.
But silent a-fib carries a stroke risk that is comparable to symptomatic a-fib. The forming clot does not care if you felt your heart flutter. The CHED, your score, does not care if you felt it.
But still, treating a 3-minute silent flutter with heavy-duty anticoagulants feels like an extreme escalation, doesn't it?
And that right there is the most heavily debated topic in cardiology right now. We recently had 2 major clinical trials, Arrhythmia and NOAA-AFNET-6, designed specifically to answer this question about smartwatch-detected microepisodes.
And what did they find?
Well, they showed a modest reduction in stroke when treating these patients, but it was heavily balanced against a higher risk of severe bleeding from the drugs.
So a trade-off.
A huge trade-off. The medical community has not settled on a definitive threshold yet. The definition of a-fib is quietly shifting from a binary diagnosis to a much murkier spectrum of electrical instability.
This tension, knowing the immense danger of a clot but fearing the complications of the intervention, it really explains why medical guidelines for a-fib have flipped so dramatically over the years, especially when you look at the debate between rate versus rhythm control.
Oh, the great rate versus rhythm debate. Yes. There are 2 fundamentally different philosophies for treating a-fib. Rate control basically accepts that the atria are broken and will keep fibrillating.
It just surrenders to the chaos.
Basically. It simply uses drugs like beta blockers or calcium channel blockers to slow down the AV node.
It's essentially telling that nightclub bouncer to slow down and let fewer people through so the ventricles aren't racing at a dangerous, exhausting speed.
Exactly. Keep the bouncer relaxed. Rhythm control, on the other hand, refuses to accept the chaos.
It fights back.
It fights back. It uses antiarrhythmic drugs or electrical shocks called cardioversion to literally force the heart back into a normal sinus rhythm.
Or they use catheter ablation.
Right. In 1998, a French electrophysiologist named Michel Haït-Séguier revolutionized this by realizing the rogue electrical signals often start in the pulmonary veins. So electrophysiologists go in and literally burn or freeze the tissue to electrically isolate those veins.
And logically, you'd think everyone assumed forcing the heart back to normal would obviously be better. Normal has to be better than broken, right?
That was the universal assumption. Until 2002.
The AFFIRM trial.
The AFFIRM trial. It was massive, and it shook the cardiology world because it showed that aggressive rhythm control did not improve survival over simple rate control.
Which is wild.
In fact, the rhythm group had more hospitalizations and adverse effects.
Okay, but how is forcing the heart back into a normal rhythm actually worse for the patient?
It came down to two major issues. First, the antiarrhythmic drugs available at the time were highly toxic. They successfully stopped a-fib, sure, but they sometimes triggered other far deadlier ventricular arrhythmias.
Oh, so the cure was sometimes worse than the disease?
Literally. Second, the patients in the AFFIRM trial had often been in a-fib for years. When the atria quiver for that long, they physically stretch out, scar, and remodel.
So you can't just electrically shock a permanently warped fibrotic chamber and expect it to behave perfectly.
Exactly. The hardware is damaged.
So for nearly 20 years, the medical consensus was to just leave most patients in a fib and slow their heart rate down. But then the eStaffNet-4 trial in 2020 flipped the guidelines again.
It did. eStaffNet-4 added a critical nuance that we missed. They found that early rhythm control does help reduce cardiovascular death and stroke, provided you catch the patient soon after they are diagnosed.
Catching it before the structural damage is done.
Yes.
If you stop the chaos before the atria permanently stretch out and scar, fixing the rhythm actually works. The timing is the treatment.
Precisely.
Yeah.
But whether you choose rate or rhythm control, you still have to deal with the stroke risk.
Right.
Which brings us to the blood thinners. And the most famous one has an origin story that honestly sounds like a Hollywood thriller. Warfarin.
This is my favorite part of the notes. This drug was not invented in some pristine pharmaceutical lab. It started in a pasture.
A literal field.
In the 1920s and 30s, farmers noticed their cattle were mysteriously bleeding to death. It turned out the cows were eating spoiled sweet clover, which contained a natural anticoagulant.
Is naturally occurring in the clover.
Researchers in the 1940s isolated the compound, decumerol, and they initially marketed a highly potent derivative of it as rat poison.
Yes. It was incredibly effective at causing the rodents to hemorrhage. But eventually, researchers realized that in carefully controlled human doses, it was a life-saving medicine.
Which is crazy to think about.
For 60 years, warfarin, derived from cattle-killing clover and rat poison, was the only oral drug we had to prevent a-fib strokes.
The journey from a dead cow to a rat trap to the gold standard of cardiac care, it's just unbelievable.
It's an amazing story. It worked by blocking the liver from using vitamin K to produce clotting factors, effectively starving the coagulation cascade. But it was notoriously difficult to manage.
It's because of the diet restrictions, right?
Right. Because it targeted vitamin K, if a patient ate a big salad full of leafy greens, the sudden influx of vitamin K would completely blunt the drug's effect.
So it required constant, tedious blood tests to ensure the blood wasn't too thick, leading to a stroke, or too thin, leading to a hemorrhage.
Which is why the cardiology world basically threw a parade in the early 2010s when the DOACs arrived, the direct oral anticoagulants.
Trials like ARLA, ROCKET-AF, and Aristotle proved these new drugs were a massive paradigm shift.
Massive. Instead of starving the body of vitamin K, DOACs act like chemical snipers. They target a single specific enzyme in the coagulation cascade like factor XA or thrombin and block it directly.
So patients can eat all the spinach they want because the drug doesn't care about vitamin K.
Exactly. And they prove to be just as effective and generally safer regarding catastrophic bleeding into the brain without needing constant blood draws.
But there are still patients who simply cannot take any blood thinner, right? They have a high bleeding risk, perhaps due to a history of gastrointestinal bleeds, but they also have a high stroke risk. What happens to them?
That is where the mechanical fix comes in. Remember that left atrial appendage, the LAA, where 95% of the clots form?
The little ear-shaped pouch?
Yes. Biomedical engineers asked a very simple question. Why thin the blood in the entire body when we can just plug the one pouch causing the problem?
Which is brilliant.
They developed LAA occlusion devices,
Yeah.
like the Watchman. The PROTECT-AF trial showed you can deploy this little parachute-like plug right into the LAA, mechanically sealing it off.
So the blood can no longer pool in the ridges?
Right. The stasis is eliminated, and the risk is structurally removed.
So with treatments ranging from freezing the heart's veins to prescribing rat poison derivatives to implanting tiny parachutes, it is no wonder patients and even clinicians fall victim to dangerous misconceptions. Let's clear those up based on the clinical notes.
Let's do it.
Rapid fire. Myth number 1, a-fib is basically the same thing as a heart attack.
Completely false. A heart attack is a plumbing issue, a blocked coronary artery starving the heart muscle of oxygen. A-fib is purely an electrical issue in the upper chambers. You could have a perfectly clean plumbing system and still suffer a massive electrical short. They are mechanistically completely distinct.
Good to know. Myth number 2. If my doctor shocks my heart back into a normal rhythm, or I get an ablation, I can finally stop taking my blood thinners.
Okay, this is perhaps the most deadly misconception of all. Even after successful cardioversion or ablation, the atrium can remain electrically and mechanically stunned for weeks.
So you think you're fine, but you're not.
Right. Silent recurrences happen frequently. Your need for blood thinners is dictated strictly by your CHA risk score, not by whatever rhythm you happen to be in today. If your risk score is high, you stay on the thinners. Period.
That's a crucial takeaway. Myth number 3, and this is a big one for anyone studying pharmacology. I don't want to take heavy-duty blood thinners, so I'll just take a baby aspirin every day. It's a safe, gentle alternative.
The Avero's trial definitively closed the door on this. Aspirin is meaningfully less effective at preventing a-fib strokes, and it still carries a real bleeding risk. Current guidelines have largely abandoned it for a-fib.
As a conceptual clarification for the nursing students listening, you have to understand why aspirin fails based on what we discussed earlier. Aspirin targets platelets. It works beautifully on platelet-rich white clots that form when arterial plaque bursts.
Yes, the white clots.
But an a-fib clot is different. As we established, it is a fibrin-rich red clot born out of stasis and the coagulation cascade in the LAA.
It's a completely different structure.
Using aspirin for a fibrin-rich a-fib clot is like bringing a sponge to a grease fire. A sponge is a great cleaning tool, but it is fundamentally the wrong chemical tool for the makeup of the problem.
I love the grease fire analogy. You need true anticoagulants, the DOACs or warfarin, to target the fibrin cascade, not antiplatelet agents.
So, to summarize this wild journey we've been on, we started in the 18th century with a physician feeling a delirious pulse at the bedside.
Jean-Baptiste de Sénac.
We moved to Willem Einthoven, visualizing the electrical chaos with a twitching string. We uncovered the exact ear-shaped pouch where 95% of these massive clots form, and we talked about calculating the risk with the CA-COYO VASC score.
And we are now in an era of modern debates sparked by Apple Watches, realizing that a-fib is a complex spectrum of electrical instability.
It's not just a simple switch anymore.
No, and if we connect all this wearable tech back to the bigger picture, it raises a rather profound question.
Oh, I like where this is going.
Think about it. If smartwatches are now revealing that huge numbers of perfectly healthy, asymptomatic people occasionally have these brief, silent flutters of a-fib.
Right, the silent episodes we talked about.
Yeah. It makes you wonder about the future of human health. When we reach a point where we can monitor every single electrical impulse of the body 24/7, will we discover that normal does not actually exist? Maybe everyone is just a little bit irregular.
I mean, if you look closely enough at any metronome, maybe none of them are truly perfect. That is something to think about. Thank you for joining us on this deep dive. Keep questioning the things you take for granted, keep learning, and don't forget to check your pulse.